Good afternoon, everybody. It's a post-lunch, post-parental session. There is a slight communication gap when we were getting the email. It was a lecture, but then it was the video lecture. So we could not convert that into video lecture. So I'll just take you through some of the steps in cruciate retaining knee. I do 99% cruciate retaining knees, even in gross deformities. And so it goes with me every time almost, the cruciate retaining knee. The slide is not forwarding. Down arrow. This one, okay? Yes. Yeah, okay. So basically, I started the knees in 90s, and I came as IB2 man at the time. But after coming to India, I changed. What made me the change? The knees in India were much smaller, about 1.5 to 2 size, and large amount of the bone removed in the box, and more problems in the soft bones. So I switched to PCL retention. The surgical advantage, pitfalls of posterior stabilizing, and biomechanical advantage. Surgical advantage is there is no box cut, so it's bone conserving. If the revision is there, good bone is available, and lesser is the time of the box cuts. And especially in the very small knees of India, the box cut sometimes fractures the condyle. And where is the pointer? You can see the small amount of the bone. Which one here? You can see that. And that sometimes is a big box cut. And unfortunately, some of the knees, whatever the size of the knee, the box size is the same. In fact, I was pleading with Mr. Ranawat to reduce the box size in PFC. And design-related pitfalls of the posterior stabilizing is patellar clunge syndrome is exclusively for the posterior stabilizing knee, inability to accommodate the hyperextension, no flexion in a femoral implant is tolerated, and post and cam dislocation fracture. These are some of the inherent PS design problems. The tibial post of the stabilized design is vulnerable to wear from rotational malalignment between femur and tibia, one by surgeon, and it may occur dynamically in gait, etc. So the biomechanical advantage of the cruciate retaining, as far as I am concerned, is the stability, and it maintains the joint line all the time. Stair climbing is supposed to be better, quadriceps function is better. It is a major stabilizer PCL in posterior and varus valgus forces. Less constraint is needed, and it decreases the chance of loosening according to the literature. Maintaining the joint line, you don't need to discuss about that. It is always there when the PCL is there. If PCL is sacrificed, flexion gap is increased almost by 5 millimeters. So distal femoral cut is also to be taken big. Then the joint line is elevated in both caps. This may cause mid-flexion instability in PS knees, so it's much less forgiving, they say. The load sharing, again, literature says PCL conserving knees are much better. And you know, John Insall kept saying that it is a soft tissue procedure interspersed with the bone cuts. Another important point which people say against cruciate preserving knees is they say PCL is almost non-functional. But this is a statement given by Dick Scott. PCL does not have to be normal to be retained. So basically 98% of the primary TKR he does it cruciate retaining, so am I. Most of the time it needs slight balancing on that. These clinical features predict the need for PCL balancing. If you got a limited preoperative range of motion, flexion contracture, or varus or valgus deformities. And before giving any thought to PCL restriction, first of all, you should remove the deforming osteophytes. Then perform the soft tissue release and align the AP axis of the femoral component to the AP axis of the femur. Match bone resection with implant thickness in extension and flexion. And what are the signs of the PCL imbalance? It's a very important test called polo test. Pull off and lift off. If the flexion gap is too loose, you can pull off the tibial implant anterior. And if the flexion gap is too tight, it will be called lift off or roll back or nutcracker effect. So that means simply the tibia will be lifted off. So this is polo test, you should do it at 90 degrees. If the tibial surface can be pulled out, that means either two things. Patella should be reduced and then done it, and then it should be a dished implant to do that. And if the PCL is too tight, you can see that the rollback is too back and the tibia is going forwards. So those two things you have to be lifted, and that is a nutcracker effect. That means the PCL is too tight. In this case, you just put your thumb on that and just release the PCL like a hockey stick in this intercondylar notch, and then it will go back. It's a very simple technical procedure. It's not a rocket science. How to balance the tight PCL? In olden days, I used to do on the tibial side, but now I do exclusively on the femoral side. After bending the knee to 90 degrees, put your thumb on the tibia and recess the ligaments on the PCL side. And sometimes you can do a tibial spine bone block osteotomy. Some people do that. That means the cruciate is here. You just conserve that island of the bone and cut the rest part of the bone. So PCL is very well preserved there. When to take out the PCL? In the sense, I am not dogmatic. Sometimes out of 1 out of 10, end of the procedure, if the PCL is not right, and if I am feeling the instability, I take that and do the posterior stabilizing. So these are the places where I take out the PCL, more anterior rollback and lift off and restricted movements. And if you go to the literature, the CR group had a greater quadriceps or knee extension movement while stair climbing by Darby and Tria from the JBJs. And another Lord Dorp, in clinical terms, the cruciate sacrifice TK is less efficient and has greater medial loading and higher joint reaction forces that may affect durability of the process. And the 12 years experience with posterior cruciate retaining totally, again by Dick Scott, one of the major proponents, he is also very happy with the cruciate retaining knee. So my experience is, as I said, last 5 years, last 8 years, more than 4,000 primary knees, only around 20 were PS, so far no complications seen in CR knees, and I'm quite happy with that. Many people, when they're starting the knees, they feel that cruciate retaining is much more technically demanding and less forgiving. It's not so at all. If you can do a PS knee good, you can do a CR knee much better. In fact, you can see very humongous deformities here, but still I have done the cruciate retaining knee, and the result is quite good. And in fact, Ashok Rajgopal is not there in this audience. He would have watched for that. He would do cruciate retaining knee even in gross deformities like that. All of them are cruciate retaining knees. And again, another deformity. As I said, cruciate need not be normal to preserve it. That is the philosophy with which we go ahead with that. So my vote in primary total knee replacement in 99 out of 100 is cruciate retaining knee. We got a time? Or how much time is that? 3 minutes, yeah. Can you run the video? Forward. Forward. Forward, yeah. Still forward. 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 Yeah. There is a cruciate retain. That is still cruciate is there very much. Forward. Forward. After all the routine bone cuts, I'll just show you how much to preserve. Forward. Yeah, still cruciate is there. Very much the gross deformity, but the cruciate is very much there. Go forward, Anand. Yeah, this all you know that. I'm not going to dwell on that. I'm going to just dwell on the cruciate retaining facets of this operation. Forward. Forward. Yeah. Cruciate, I have not touched the cruciate at all. Still cruciate is there. Forward. That is the posterior cruciate. Forward. The only thing is you should have a special bifid retractor, which I will show you. That is the one. That is a bifid retractor which has got 2 prongs which will go on either side of the PCL. And now when you cut the bone, you should not go, the saw should not go right in the middle part to the posterior aspect. So that should be preserved in the sense. And when you lift off with the osteotome, you should not go on the central part, go on the lateral and medial parts so that the central part of the island is left or the PCL is not damaged. And another point here is, most important point is you should have a meniscal grabber like that. You hold the tibial cut with that and pull it, and then with the diacer make a cut around the PCL here. So that is the important point. In the normal PCL sacrifice, you just cut it through and through. But here, PCL is still well preserved there, and that is the important point. In the tibial side, that is the PCL. That is the PCL is still there. And the rest of the things are very normal. Of course, if you have said in the ligament balancing, if you need, you will balance on the femoral side. In summary, cruciate retaining is as good as the posterior stabilizing knee, coming to the technique is concerned. Number 2, there are some surgical steps which are to be taken care. Number 3, you need not be dogmatic that cruciate has to be retained. If you are in doubt, you can take it off. Number 4, if the cruciate is tight, you can do the balancing on the femoral side. And those are the 4 important points. With that, cruciate retaining can serve you as good as the posterior stabilizing knee. Thank you so much.